Hello, everyone. My name is Leo, and I'm currently serving as the Chief Diversity Officer of National Alzheimer's Buddies.
Hi everyone, I'm Vidushi. I'm currently a DEI intern at Alzheimer's Buddies.
Hi everyone, I'm Vega and I'm also a DEI intern at Alzheimer's Buddies.
So this is the sociocultural portion of the NAB volunteer training. By the end of this module, you should be able to define terms related to diversity, equity, and inclusion, and become aware of social and racial disparities in dementia care. You should understand the social determinants of health and how they shape the concepts of diversity, equity, and inclusion. You should be able to identify cases of discrimination and recognize implicit bias. You should know how to respond when encountering microaggressions, and most importantly, apply an understanding of diversity, equity, and inclusion to volunteer interactions with buddies. At the core of the sociocultural module in the National Alzheimer's Buddies volunteer training is diversity, equity, and inclusion, oftentimes abbreviated as DEI. Diversity refers to the representation of different communities, backgrounds, cultures, identities, abilities, and beliefs. This can include aspects such as race, ethnicity, nationality, gender, religion, age, and many, many other components of identity. At its core, diversity is really about embracing a wide breadth of experiences, perspectives, and backgrounds. Equity refers to a state of fairness and justice in the treatment of individuals. This is different from equality, which occurs when all individuals receive the same treatment. Not all people begin on an even playing field. Oftentimes, due to structural inequalities that exist for certain identities and groups, simply giving individuals the same tools is not enough to make sure everyone has the same opportunity to succeed and overcome these societal barriers. Consequently, certain individuals may experience more obstacles than others when trying to achieve the same goal. While equality involves providing everyone with the same exact resources, equity allocates resources based on individual needs, acknowledging that there are obstacles in society that exist for some and not others. Finally, inclusion refers to the effort to build a culture where all people feel welcomed and respected. An inclusive environment acknowledges individuals from a myriad of backgrounds, addresses discrimination, and makes everyone feel encouraged and empowered. As we proceed through this module, consider how an understanding of the social and cultural components of dementia is essential for acknowledging diversity, promoting equity, and fostering inclusion. As volunteers, we always want to be considering the principles of DEI in our interactions with buddies. In addition to diversity, equity, and inclusion, we also wanted to introduce several other relevant terms for this module. Discrimination refers to the unjust treatment of different groups of people on the basis of certain characteristics or identities, while prejudice refers to the preconceived negative opinions people may have that are not based on reason or real experience. In other words, discrimination constitutes external action, while prejudice constitutes internal beliefs. Prejudice can be categorized as a type of implicit bias, which refers to judgments, decisions, and behaviors that often occur unintentionally and automatically. This is something we all need to put effort into dismantling, and we hope you all can become more aware of your own biases throughout this training. Similar to prejudice, stigma refers to the disapproval of an individual or group based on a characteristic distinguishing them from other members of society, such as illness. The mission of NAB is to empower students and buddies to break through the boundaries imposed by dementia and discover a new identity together. Let's break that down in the context of diversity, equity, and inclusion. Our mission states that we want to break through boundaries, and in a DEI context, we do this by learning about our buddies' life experiences that may be vastly different from our own. We also hope that an understanding of DEI can help you as a volunteer or director to better understand the sociocultural factors that affect the care those with Alzheimer's disease receive. Our mission emphasizes the idea of togetherness. We hope that we are able to respect each other regardless of race, gender, sexual orientation, ethnicity, and the factors that influence our identities. Extending this one step forward, our hope is that we can build a culture of empathy within each chapter and our organization as a whole. Finally, through reflection at the national level and with feedback from individual chapters, we know we also have work to do as an organization. Many of our chapters work with affluent groups of people that have access to specialized care through residential memory care facilities. As an organization, we want to move in the direction of making access to support more equitable. Our community chapters, which have been previously mentioned, are the first step we've taken in this direction. Before we get any further into this content, we would like to remind everyone that National Alzheimer's Buddies aims to promote an inclusive and safe community. NAB does not tolerate any forms of discrimination. Anyone can be an advocate for change, so individuals who do not consider themselves members of a minority group should not feel discouraged from taking the lead on providing DEI training. However, individuals who are members of a minority group should also not feel obligated to serve as facilitators.
As Alzheimer's is becoming a growing issue within medicine, more equitable provision of Alzheimer's care is becoming a topic of increasing priority. Currently, studies show that there are major discrepancies regarding who actually faces Alzheimer's disease. The Alzheimer's Association reports that almost 2/3 of Americans with Alzheimer's are women. And sadly, older Black Americans are about twice as likely, and older Hispanics are about 1.5 times as likely to have Alzheimer's compared to older white Americans. These disparities in incidence rates are heightened by further disparities that present themselves when those affected seek treatment. Studies show that 50% or more dementia caregivers of color say that they have faced discrimination when navigating care for their recipient, and many of these complaints report themes of not being listened to, not being respected, and not being cared for as much as other folks might be. Ultimately, people of color want healthcare providers who understand their unique experiences and backgrounds, but fewer than 3 in 5 feel confident that they have access to culturally competent providers. If the majority of our population has difficulty accessing competent care, something must be changed societally. If medicine is to remedy ill health, then it must also remedy the social differences at the root of it. The field of healthcare is growing increasingly dedicated to this goal, as there have been increasing efforts to boost diversity in dementia care, engage and recruit diverse populations for Alzheimer's research and trials, overcome language barriers with bilingual staff and interpreters, and provide training to providers on cultures represented within their community. As the field incorporates these changes, our population will enjoy access to better and more competent care.
As we hinted at in the previous sections, social and cultural factors are the driving force behind many of the disparities that we have observed in the incidence rates and quality of care of those with Alzheimer's. These social determinants play a significant role in health outcomes as they create economic, social, environmental, and physical health issues. For example, employment, income, housing, transportation, and access to healthcare all derive from economic and environmental factors of health. Components such as language barriers, discrimination towards certain groups, access to education, and support systems all contribute to social, community, and education factors of health as a whole. When it comes to dementia care, the following social determinants of health are crucial for determining the outcomes of care: freedom from discrimination and violence, social inclusion, access to economic resources, access to healthcare, quality of healthcare, and access to transportation. BIPOC communities often face barriers in getting diagnoses for dementia-related illnesses or even accessing memory care. Findings in the Alzheimer's Association survey showed that 1/3 of African Americans and 1/5 of Hispanic Americans and Asian Americans experienced barriers when accessing dementia care. When examining non-white caregivers, half or more say that they have faced discrimination when navigating healthcare settings for their care recipient. This is a table of the perceived barriers to getting excellent healthcare and support for Alzheimer's and other dementias based on race. Across the board, Americans feel that affordability of care is the biggest barrier to dementia healthcare. Lack of good healthcare coverage, lack of good services in their community, and lack of family and social support are also pretty significant for all demographics. However, the barrier of being treated differently because of race, color, or ethnicity is higher for Hispanic, Black, Asian, and Native Americans compared to white Americans. Social determinants of health can affect our buddies. For example, status can determine how much and what quality of healthcare buddies have to memory care facilities and programs specialized for dementia and Alzheimer's. Language barriers can make it difficult for buddies to interact with doctors and medical professionals. In addition, differences in language could affect our buddies' interaction with volunteers. Depending on different social determinants of health, buddies may be diagnosed with dementia or Alzheimer's later in life.
Stigma, also known as explicit bias, is when an individual is aware of pre-existing beliefs and intentionally makes decisions on those beliefs, while implicit bias is unconsciously influenced beliefs. Both are major social determinants of health, as they may disqualify individuals or groups of people that live with certain health conditions. Those on the receiving end of implicit bias and stigma may avoid care or be unresponsive to treatment, resulting in disparity in care. There is a public stigma towards all kinds of cognitive impairments, including Alzheimer's. Stigma occurring after a diagnosis could be seen in how a caregiver reacts to the diagnosis, how the patient reacts, and as well as how others, including healthcare professionals, treat the patient after. Take a minute to pause the training here and read the scenario. When you have read the scenario and thought about an explanation, unpause. There are many explanations you may have thought to explain this scenario. However, the easiest explanation in this scenario is that the surgeon is the mother of the injured patient. For a variety of reasons, people may have the viewpoint that the surgeon was a man, and this is an example of implicit bias. It is important to know that everyone has biases, and over time, you'll uncover more implicit biases that you hold. Implicit biases are dynamic. Therefore, it's important to be aware of our biases and alter them if necessary.
Take a moment to pause the video and read through the case study. Unpause the video once you have finished reading the study. Now that you have read through the case study, we will go through a series of questions that ask you to analyze and reflect on the effects of implicit bias. Our first question is, what assumptions were made about Harold? Please take a moment to pause the video and write down your answer. It was assumed that Harold was overdramatic, lazy, unintelligent, and dishonest. These harmful and utterly false stereotypes based on skin color were applied to Harold. Let us remind you that race does not determine intelligence, and this stereotype is far from the truth. The second question is, how is implicit bias present in this scenario? Again, please take a moment to pause the video and write down your answer. The dismissive behavior by the physician shows that she was acting on her own implicit biases. Rather than treat Harold as an individual with a unique background that must be learned to properly assess his condition, the physician instead uses her own preconceived notions about Black people to guide her medical decisions. The nurse using the words, quote, "these people," further reinforces the severely problematic stereotypes that this healthcare team harbors, which are likely used to discriminate against and invalidate the experiences of all patients sharing this racial identity. In these cases, the delayed diagnosis means that implicit bias is causing real physical harm to patients. The third question is, what could have been done differently in this situation? Again, please take a moment to pause the video and write down your answer. In this case, the screening physician should report the comments that the outpatient physician made, especially since the implicit biases in this case study have the potential to harm many other patients apart from Harold. A physician should never base their medical decisions on untrue assumptions about their patient. The outpatient physician should have truly listened to her patient's concerns about their health. Our final question for this case study is, how can you be an advocate in a situation like this? Please take a moment to pause the video and write down your answer. You can be an advocate in a multitude of ways. First, recognize your own implicit biases and avoid snap judgments. Second, do not be afraid to speak up and confront someone if you notice they are making covertly racist comments, especially in situations like these that are placing the victim and potentially others at risk. You may choose to intervene by reminding the outpatient physician of their duty to treat all patients with respect, regardless of their racial, gender, or sexual identity. You should make a comment informing the physician that these stereotypes are completely unfounded and extremely harmful to Black patients seeking care. Regardless of how you choose to intervene, it is important to not come across as attacking the other person. Make sure that they understand that you are trying to show them why their actions are not appropriate. Lastly, if you do not feel comfortable speaking up in this situation, please immediately report to someone with higher authority. We want to continuously foster an environment that is safe, accepting, and intolerant of hate. Something that is important to consider after reviewing this case study is that some of these actions may not seem explicitly racist or hateful. However, this does not mean that they are not harmful and can still have severe repercussions. Bias can have a tremendous impact on an individual, a community, or an entire population. Bias, as we have observed, can even influence the outcomes of one's own health. Implicit bias is pertinent in all realms of life, especially in healthcare. It is known that non-white patients receive fewer cardiovascular interventions and fewer renal transplants. Black women are more likely to die after being diagnosed with breast cancer, and younger individuals may not be screened for dementia or Alzheimer's disease. All of these examples are the result of implicit bias and assumptions made about patients based on their physical appearances.
Implicit bias and stigma often manifest themselves as microaggressions. Let's move on to learning what microaggressions are. Microaggressions are comments or actions that subtly express a prejudiced attitude toward a member or a marginalized group or minority. It is the everyday slights, insults, put downs, invalidations, and offensive behaviors that people experience in their daily interactions. It must be noted that oftentimes the person that engages in microaggressions may not intend to be offensive. Despite this, microaggressions still matter and their impact can still be negative regardless of the intention. It is crucial to not unintentionally reinforce any form of oppression or inflict accidental injury on others. One thing we want to emphasize is that anyone belonging to a marginalized or minority group can experience microaggressions. This table contains various samples of common microaggressions. So how do microaggressions apply to Alzheimer's buddies? You may witness microaggression in NAB when reviewing applications for volunteers, volunteering with our buddies, interacting with other volunteers, or reflecting on our experiences with our buddies. While we hope that this does not happen, we want to be transparent about potential outcomes and prepare you for a response.
Whether you witness someone else committing a microaggression or personally experience a microaggression, we want to provide a set of tools that can help you navigate these situations. The first step is to simply recognize that a microaggression has occurred. The second step is to decide whether to respond to the microaggression or not. Some questions that may guide your decision may include the following. Please pause the video to review these questions. These questions are all factors you may need to consider when choosing your response to a microaggression. The third step is to figure out the intent of your response. It is much easier to choose a strategy on how to respond to a microaggression with a goal in mind. Some goals you might consider including modeling to others that this behavior is unacceptable, directly confronting the perpetrator, or protecting the victim from further harm. The following are a couple different responses you can have to microaggression if you do choose to intervene. You can ask for clarification by saying something like, "What do you mean by that?" By creating an environment that encourages discussion, you have the space to truly understand the other person's intentions and potentially educate them by targeting their specific biases. Please remember that you are not obligated to educate anybody, but if you have the emotional and mental capacity to do so, this is a good way to encourage that the microaggression does not happen again. You could also share your growth by saying, "I used to think that way until." Interestingly, you can also appeal to their admirable values. This means you are reinforcing the other person, validating any inclusive values that they already have, and showing how their microaggression contradicts these values. "I know you care about blank." Acting this way undermines those intentions. You could keep it quick and to the point by saying something like, "That is not okay." Or you can challenge the stereotype with your own experiences or promote empathy by asking, "How would you feel if someone said you said that?" Now we will move on to another sample scenario. Pause the video here and consider your response. In this scenario, Ashley is a new volunteer for NAB. Her buddy notices that she is a person of color. "Where are you from?" her buddy asks. Ashley says that she's from New York. Her buddy responds, "No, where are you really from? You look so exotic." Now please take a moment to read the following questions and discuss your responses. Ashley recognizes that the buddy's comment is a microaggression. No matter her buddy's intentions, their comment is demeaning towards Ashley's racial identity. If she feels safe to do so, Ashley can respond to the microaggression by explaining that the question is harmful by stating, "It is offensive to imply that I was not born here based on the way I look," and by educating them about the language they used. Ashley can also let her chapter director, a nurse, or a facility worker know about the discrimination she endured if she does not feel safe addressing it directly. One important thing to consider is that buddies are in varying stages of dementia, which can result in repeated microaggressions. If this comment is repeated in subsequent visits, Ashley should choose to immediately inform a nurse or facility worker. As a chapter, it is important to ensure that all volunteers feel comfortable regardless of race, ethnicity, gender, sexual orientation, disability, education, etc. It may be helpful to create ground rules for buddies so that they have clear guidelines on what is and what is not acceptable. Here are some preemptive measures that you can take to avoid performing microaggressions yourself. Some suggestions include being vigilant of your own biases and fears. Seek out meaningful interactions with people who differ from you in terms of race, culture, ethnicity, and other qualities. Don't be defensive if you are accused of microaggression. View it as an opportunity to learn. Additionally, be open to discussing your own biases and how they might have hurt others in some sense. Reveal biases on your part. Be an ally by personally standing against all forms of bias and discrimination. Finally, do not take offense on the behalf of others. This is often a microaggression itself and exemplifies a savior complex. Learn from the many examples of microaggressions that have been chronicled in articles, research, and social media. Once you hear about how they affect people, chances are you'll be more aware of what they look like, and suddenly much less likely to repeat them.
Now that we've discussed several key topics related to social determinants of health and DEI, let's transition to how we, as National Alzheimer's Buddies volunteers, can use the knowledge from this training module to reduce disparities in Alzheimer's care. It is important that we work together to enact structural change. Even if there are currently no NAB community initiatives near you, there are ways to incorporate DEI in today's training into your chapter as well. We have compiled several ideas here, but feel free to use your creativity and create ways that best connect with your community. Here are some of the ideas we have included. Encourage the participation of volunteers and buddies that speak multiple languages. Discuss DEI-related issues at reflection meetings. The DEI committee will be releasing a series of case studies to chapter directors to use during these meetings. Create a safe, inclusive environment for all volunteers and buddies. And finally, reach out to under-resourced community centers and incorporate community-based principles into your own chapter. If you encounter any DEI-related issues or would like to voice your concerns, there are many individuals here to support you at National Alzheimer's Buddies. You are always welcome to contact the directors of your chapters to raise your concerns. At the national level, feel free to contact me, our CEO Jillian, our DEI community head Andy, or any of our DEI interns. We are more than happy to help you and work with you to address any questions, concerns, or feedback. Comments can also be submitted anonymously to the Google form linked here in the QR code. Additionally, please feel free to take a look at any of the resources we use to create this training. Thank you.